Yes, sir.
C.W. Kim from Hong Kong. Great pleasure listening to a very enlightening talk. Just wish to understand, appreciate, since there could be bundles or changes concerning the safety management, so how could you attribute how many percentage was contributed by the simulation training in contrast to other concomitant activities in order to substantiate the real importance of clinical simulation?
So the question is about the data that I show, I believe, on obstetrics being attributed to the changes to the simulation training and like activities compared to other changes that have occurred over a similar time frame. And so that's an excellent question. The data that I showed are actuarial data. They're not research data, which is another problem with that notion. However, the insurance company has compared their data with the insurance company in the surrounding region and in regions around us and has not found that same drop in claims. And so there is some evidence that changes have occurred. I guess to my eyes, as I've watched how obstetrics is practiced in our institution, I can see dramatic changes in the way practice is conducted since we started doing the training. And I don't take credit for making those changes. All I can think of is that the simulation training that we do help catalyze a different way of looking at their practice. And so if I could characterize in a nutshell what's so different, it's teamwork. They approach obstetrical care much more from a teamwork perspective than they do from an individual perspective. Before we started this training, the individual obstetricians owned their patients very tightly. In the ensuing years, the change that we see is that every obstetrician and every labor nurse on the floor takes some responsibility for each and every patient. People are much more willing to speak up when they see something that they're not comfortable with, and people are much more willing to receive input from others on the obstetrical team. And so I do believe that there's been an effect of that kind of training, although, as you point out, it's very hard to prove a cause and effect relationship. Any other questions? There's one in the back. Young lady running down the corridor there.
Harry Owen from Flinders University in South Australia. Dan, it's really a little comment on Semmelweis. I'm not quite as old as you, but I have the same interest in history. Semmelweis actually lost his job because of his theories about hand washing and hand hygiene. As a result, he applied to the authorities in Vienna for a private lectureship, and they gave him that, but the condition was that he only taught using mannequins.
Really?
So it actually, although he started with patient safety, and he was actually forced into the position where he had to teach with mannequins. Sadly, he didn't think that was very good, and he shot through back to Budapest, but mannequins and Semmelweis.
Thank you, Harry.
Stefan, from the United States, at the present time, Georgia Health Sciences University, talking about the same Ignaz Semmelweis. There were two hospitals very close to each other. In one of them, the babies were delivered by the nurses. In the other one, the babies were delivered by the physicians. And the rate of mortality and all of these problems was very high in the one where the physicians delivered compared to the nurses. So speaking about safety and the ability of express concerns about it, a lot of the bee mothers insisted that they have to go to the other hospital because they knew what was going on. Reason being, that the physicians were spending 2 hours in the morning dissecting and then going directly to the hospital, which was not the case in the other hospital.
Yeah.
But this was understood much later.
Yes, and I understand some women actually delayed going to the hospital if they were assigned to the physician's hospital and delivered on the street because they felt it was safer than actually making it
Correct.
to the hospital. Any other questions other than Semmelweis? One over here.
Jürgen Muglia from Sydney. I'd like to know how you managed to convince your medical faculty to introduce simulation into your medical education training program. Harry Owen might be able to answer that from Flinders, because I find it extraordinary that we've got a very large medical faculty training program in University in New South Wales, but it is not mandated that it is included in the medical training program.
So that's a great question. How did we convince our medical faculty to participate in simulation? And I must say that it was not an easy task. Jeff Cooper, who's the director of our simulation program and a famous patient safety person, was the leader who took it forward. So I think there were several ingredients, several of which I've spoken about. One was convincing the insurance company that there was value in this. And so they put forth this incentive that had real money behind it that was difficult to push against. So if you're a physician and you're paying $6,000 to $8,000 more for your malpractice premium, and you have to go spend a day playing with dolls, you might go play with dolls. And so that was very helpful. Getting the leadership convinced, I think, is a real key element. And so Jeff somehow cajoled the leadership to participate in simulation in every program that we've started. And so the first time he did this, he got the chiefs of anesthesia from the 4 Harvard teaching institutions and said to them, you know, if your residents are doing this course and learning about patient safety, why don't you do it? And they were quite reluctant, but he kind of shamed them into it. And they came and they took a course themselves as a group with great secrecy. Nobody knew the day they were coming, and nobody could be there. And at the end of the course, they said 2 things. One is all the instructors need to be taken out back and shot. And number 2, everyone needs to do this. They saw the value of it. And from that day forth, they convinced their faculty that this was a good thing and that they should do it. That pattern, that model, has persisted in all of the successful inclusion of faculty in our institution. So convincing the leadership, making them participate in simulation, having them see the value of it, working at all levels to convince people this has worth to it, in our case, financial worth, and then being very careful and working really hard to make the program they participate in really, really good. Any other questions?
Professor, I come from Shanghai, China. I have a question about the history about the simulation. You see in China, there's a national treasure. About 1,000 years ago, there's a human, an adult body made of bronze, and the size is as large as a human being. And inside is the mercury. And this body is just used to training the Chinese doctor about their architecture skills. So if you do the right thing, then the material will come out, and if you do wrong, and nothing will come out. So I don't know whether this kind of body is just simulation training. So if it is, I think maybe the history of about the simulation will maybe when they will not only the 19th, but 1,000 years ago. Thanks.
Thank you. Yeah, I bet if we look hard enough that we would see simulation being practiced in various forms in early healthcare thousands and thousands of years ago, because it's an idea that makes so much sense, and I'm happy to hear that there's evidence of it here in China. Okay, thank you very much.